so you guys don't have to hear all that dinging. It's close. It's just setting up YouTube. Okay, you guys are live.
It's my pleasure to introduce Dr. Rudock, Assistant Professor of Neurology and Pediatrics at Washington University in St. Louis. He is also the Medical Director of St. Louis Children's Hospital and Sleep Center. With that, he is going to share with us a presentation on sleep and CDKL5 deficiency disorder.
Thank you very much, Heidi. So I'm honored to be here today to talk to you about how sleep is so important in CDKL5 deficiency disorder. And what I'm hoping to kind of do is give a broad overview of what's going on in terms of sleep with this unique disease. And so how I have structured the talk for today is in a question and answer format, kind of touching on 4 different main questions. The first question, which we'll touch on briefly, is how commonly do sleep problems occur in patients with CDD? The second is how does CDD affect, or why does CDD affect sleep so much? Then what specific sleep problems can occur with CDD? And finally, the question most people are probably interested in is how are these sleep problems actually treated? And we'll be spending the majority of our time kind of talking about that last question. So to start off, how commonly do we actually see sleep problems in kids with CDD? Well, very commonly, in fact. About 86% of patients with CDKL5 develop some kind of sleep problem at some point in their lives. And so that's a very high percentage. And so that means almost everybody is affected. Additionally, boys may be affected more than girls. So almost 95% of all boys who have CDKL5 have some kind of sleep problem that they develop during the course of their lives, while girls, the number is a little lower, closer to 85%. Now, if you're thinking, well, this is not very good news, it means that we're going to have sleep problems forever, that's not necessarily the case, because an interesting thing that we've noted with CDKL5 is that as kids get older, the chances that they are going to have a sleep problem at that time actually decrease. So kids who are between 0 and 5 years old generally have sleep problems 40% of the time. Once they hit that 5-year-old mark, the number decreases to about 1/3. And then once they hit that 10-year-old mark, the number decreases again to about 1/4. So what this really means is that while you may be facing some sleep problems at a young age, as you get older, things are likely to improve, although they may not go completely away. The second question is in terms of the why part. Why does CDD affect sleep so much? And so in order to really understand this, we need to think about the different problems that are associated with CDD. We know that kids with CDD frequently have seizures, which is a hallmark of this disease. Also epilepsy, so repetitive seizures. They have developmental delay and intellectual disabilities. Their muscle tone tends to be low. And also they often have problems with just visual abilities or visual impairment. And I'm not talking here about needing glasses or not being able to see well in terms of your eyes, but I'm talking more about how the brain processes visual information. So all those things are often associated with CDD, and each of these things specifically is associated with a unique set of sleep problems. And so what I want to do now is talk about those specific problems with CDD and those unique associated issues that are going on. So the first and one of the most prevalent are seizures. So as many of our families know, when you have a seizure afterwards, you can be kind of tired. So that's called post-ictal sleepiness. If you have a seizure and you're tired right after during the day, you may be tempted to kind of sleep for, could be 10 minutes, could be 3 hours. It kind of varies from person to person. But if you're sleeping then more during the day, when nighttime comes along, it is more difficult to fall asleep because you've been sleeping all day. Additionally, if you have a seizure, you might become agitated or kind of hyperactive afterwards. And if this is what's going on, it may take a little time for you to kind of wind down and calm down to your normal state. And so if this happens right before bed, it may make it, again, more difficult to fall asleep before bed. Some people have seizures only when they are asleep and don't have any seizures while they're awake. Those are called nocturnal seizures. There are arousal associated seizures as well. And so one of the things you may notice is that when somebody is more kind of drowsy, they're more likely to have a seizure. And these are the arousal seizures that I kind of alluded to. Finally, if you have seizures and CDD, which almost all of our kids do, you are often not just on one medication, but you're often on multiple medications for your seizures. And as we go up on medications for seizure control, one of the trade-offs is side effects. And so going up on seizure medications can make you more drowsy or tired during the day. There is one kind of exception to this rule, and that is with the medication called felbamate, because felbamate is a medicine that ironically makes it difficult to fall asleep, and it can kind of make you a little more hyper alert. And so if you take felbamate right before bedtime, you may notice that it is more difficult for you to fall asleep. Sleep deprivation inevitably leads to more seizures, and seizures inevitably leads to more sleep deprivation. And then we can end up in this cycle where things are feeding into each other. And the best way to kind of break that cycle is not by focusing on one or the other, but it's kind of by focusing on both of those things simultaneously. The second area where we see a lot of problems in terms of sleep with CDKL5 is with developmental delay. Children have insomnia for different reasons than adults do. Adults tend to have insomnia because they have difficulty kind of quieting their mind. They may be worrying about the next day or replaying what happened during that day. And so that is different than why a child might have insomnia. And for the most part, children tend to have insomnia because of behavioral associations. And what I mean by behavioral associations are specifically sleep associations. And so a sleep association is anything that somebody associates with falling asleep. I personally have a sleep association with my pillow. For example, at nighttime, I get into bed, I move my pillow around and I go to sleep. If I were to wake up in the middle of the night and notice that my pillow were missing, what do you think I would do? Most people would say you would get up out of bed and look for your pillow, which I would. And so children also have sleep associations, but they tend to establish sleep associations with mom and dad more so than anything else. So if you're laying down with your child in order to help them fall asleep, when they wake up in the middle of the night, they're going to seek you out in order to help themselves fall asleep because they've associated you with sleep. And I will also add that waking up in the middle of the night is normal. Everybody wakes up in the middle of the night. The average time is around 8 times per night. Most people kind of roll over. Other people might become more alert and kind of sit up and be very wide awake. So the waking up part is not the problem. It's what you do when you wake up. And so what we try to do if a child has established an association with mom or dad is try to break that association and replace it with something else. Sometimes that might be a favorite blanket or a favorite stuffed animal or some other object. The ultimate goal, however, is to have your child associate falling asleep with being drowsy. And we'll talk about how we do that in a later part of this talk. The other part of insomnia in children is called limit setting. So as a normal part of development, children want to kind of push limits, right? They want to see what they can get away with. And that is developmentally a normal thing that all children do, regardless to whether or not they have CDKL5 or not. And so sometimes this can be in the form of kind of whining at bedtime, making excuses as to why you can't go to sleep, or just kind of pushing back against sleep when it's time to actually go to bed. And so this normal part of development can sometimes spill over into nighttime, and then start to affect sleep. And then we are led to have bedtime resistance and different behavioral problems like that. The big point here is that insomnia in kids doesn't tend to be related to the same things as in adults, but insomnia tends to be more related to different behaviors in children. And for somebody who has a developmental delay, those behavioral things tend to be exacerbated or worse than compared to a child who doesn't have developmental delays. Low muscle tone. This goes by a lot of different names. Sometimes people will refer to this as hypotonia or just being kind of floppy. But when your muscle tone is lower than average, that increases your chances of having something like obstructive sleep apnea. And so in this picture, you can see where there's normal breathing. The blue represents airflow, and it kind of comes in through the nose and down through the back of the throat into the lungs. If you have low tone, then your tongue and your palate, that's the back portion of your throat, are more likely to fall backwards and kind of block that air. And that's what actually causes snoring. It's the rubbing and the flapping of these tissues in the back of your throat. If those tissues fall back completely, that's called an obstruction, and that's what we see in obstructive sleep apnea. Visual impairment. So as I mentioned before, we are not talking about the eyes not working properly. We're talking about how the brain is processing visual information. And so over here, what you see is that when it is light out, we have inhibition of what's called melatonin, okay? Light prevents the release of melatonin. Over here, when it's dark out, we have stimulation of melatonin. If you look at what's going on with this graph over to the right, the light part represents the daytime, the blue part represents nighttime, and this line is what melatonin is doing. And so during the day, when it is light, melatonin is being blocked and it's kept low. When it becomes dark outside, melatonin is released and it increases. And then as it comes to the morning time, it goes back down. And we continue this cycle of going up and down with daylight and nighttime. And if you are able to process that information properly, wonderful, we have a good cycle. But if your brain does not process that information correctly, then sometimes that can lead to disruption in what's called your sleep-wake cycles or your circadian rhythm, which we'll talk about in just a little bit more. So that is the why part of why CDD affects sleep so much. Now, what specific diagnoses and specific sleep problems are going on? So the first one is insomnia. This comes as no surprise to any of our families. And insomnia is a fancy way of saying you have trouble falling asleep or you have trouble staying asleep. It can be either one of those things. Circadian rhythm disorders are those sleep-wake cycles that I alluded to. And these are problems where what happens is you should be awake at certain times, but you're asleep, or you should be asleep at certain times, but then you're awake. And this is an example of the different types of circadian rhythm problems that you can have. Here in the gray rectangle is, generally speaking, when most people should be sleeping. And this light blue bar is when somebody's actually sleeping. So for a normal sleep-wake cycle or circadian rhythm disorder, you go to sleep at night and then you wake up in the morning. For an advanced one, you're going to sleep early and waking up early. This is the pattern we often see in older individuals or the elderly, where they go to bed at, say, 7 in the evening and wake up at 4 in the morning. Additionally, if you fall asleep later and wake up later, that's a delayed phase circadian rhythm problem that you're having. This is very, very common in our teenagers and also young adults. We call these people night owls. They just like to be awake at night and asleep during the day. There's an irregular sleep pattern that you may see. This is where somebody is sleeping for a couple hours, maybe 1 hour, and then is awake an hour, And this pattern just continues throughout the day, throughout the night, and there's no real consolidation of sleep at night or wakefulness during the day. It's kind of back and forth throughout the day and throughout the night. And the last pattern we sometimes see is this non-24-hour pattern. And this is where you might sleep well one night, you go to bed at a normal time and you wake up at a normal time, then during the day you're feeling good. But over time, you tend to fall asleep a little later, then wake up a little later. And then the same thing kind of continues. So if you're trying to go to bed right here, you might have insomnia on this night, but not on this night. And on this day, you might be more tired, but on this day at this time, you're more alert. If this pattern continues and it continues to be later and later, you might have a night where it seems like your child just doesn't sleep at all. And it's because we're seeing a pattern like this over time. Restless sleep. Restless sleep is a newer clinical entity, meaning it's a newer diagnosis that sleep doctors have just started to really recognize. And it's something that is being researched pretty extensively right now. What this is really just moving around a lot at night, kind of tossing, turning, never really getting comfortable. And this can sometimes be related to a bunch of different sleep problems, the most common being iron deficiency. As we talked about before, you can have things like sleep apnea with CDD. You can have obstructive sleep apnea like we talked about, which is related to having an obstruction in the back of your throat and your airway, or you can have central sleep apnea. Central sleep apnea is a little different because this is when the brain is telling the body to stop breathing. And it's important to distinguish obstructive versus central sleep apnea because we treat both of these differently. And then the last big thing in terms of specific sleep problems in CDD is daytime sleepiness. And because of all the things we talked about before, if you're not getting good quality sleep, you can have daytime sleepiness. If you're on medications, you can have daytime sleepiness. And it's only by kind of talking to your sleep physician and in great detail where we're able to tease out these different problems and try to tackle all the different things that may be contributing to daytime sleepiness. Some unique problems with children who have CDKL5 include teeth grinding. The medical term for this is called bruxism. You can sometimes also have night screaming or night laughing. And so this is very similar to something like a sleep terror, where somebody is definitely asleep, but they're crying out, they're yelling. Sometimes they may be talking. All those different things and noises that somebody makes are kind of grouped into a category of diseases called parasomnias. And so that's what those are all describing. And the last unique thing that we sometimes see in kids with CDD are repetitive movements with falling asleep. And so sometimes you can have what's called head banging, where somebody is banging their head on the headboard. Sometimes there may be rocking back and forth, left to right, kind of forward and backwards. And these are things that children can sometimes do in order to help them also fall asleep. We don't think any of these things are dangerous, okay? If you have some head banging, generally what we recommend is kind of putting some padding on the head of the bed, and then also looking for other causes of sleep disruption. And now the last part of our talk today. How are these sleep problems treated? This is, again, probably the area that most people are interested in. And so for insomnia or difficulty falling and staying asleep, the mainstay for treating this is with something called cognitive behavioral therapy for insomnia. This is a fancy way of saying we train the brain to know when to be awake and when to be asleep. In order to do this effectively, you really need to work with an expert called a sleep psychologist. Most people have never heard of a sleep psychologist, and that's for good reason. There's not a lot of them out there in the world. A sleep psychologist is somebody who has extra training in sleep medicine, and they work with people in order to help them become better sleepers. And so it's not necessarily that they are talking to your child about why they can't go to sleep, but they're talking to mom and dad about different techniques and strategies about how they can modify a child's environment in order to help get them into a better state of mind and a more quiet state of mind before bedtime so that they can fall asleep. Additionally, they talk to mom and dad about different ways to respond to a child when they inevitably push back about not wanting to go to sleep. And again, we want to maintain sleep as a positive experience, and we don't want sleep to turn into a negative experience. So we don't want mom and dad to get frustrated or upset, because that is normal. When your child won't go to sleep, you're tired, it's very easy and normal to get upset at that time. But we want to kind of train everybody so that we can keep this a positive experience moving forward. This technique of CBTI is extremely effective, extremely effective. In fact, when they do studies to compare certain sleep medications to this approach is always more effective. Additionally, there are lasting effects, meaning you can do a few CBTI sessions and you will continue to be a good sleeper, versus if you are on a medicine, if you stop the medicine, then you no longer are able to sleep. The thing I like best about CBTI is that there are no side effects. For kids with CDKL5, they're often on a lot of medications, a lot of seizure medicines, and a lot of those medicines affect your brain and your thinking. And if I'm able to avoid adding an extra medication, I think that's a win-win. Now, that's not to say we don't use medication, because using these behavioral interventions can only go so far. One of the most common medicines that we use is melatonin. Melatonin is very well tolerated. We think that it is a very safe medicine, but it is considered to be a dietary supplement. And I say that on purpose because that means different brands of melatonin have different purity levels. And so some brands of melatonin might not have as much melatonin as you think, and some brands of melatonin might not actually have any melatonin. And so just because somebody has not responded to one brand of melatonin doesn't mean that if we were to put you on a different brand that you wouldn't respond, because you might, okay? Melatonin is also used to affect your circadian rhythms, as we talked to. So not only does it help you get a little more drowsy, but it can affect your sleep-wake cycles. In addition to melatonin, there are a whole slew of other sleep medicines that we will sometimes use. In children with CDKL5, our ability to use some of those medications is limited because often those kids are on seizure medicines, and there can be interactions, or those medicines might increase your risk for seizures. So it's not uncommon for us to reach out to a patient's neurologist or epileptologist about whether or not they would be comfortable starting one medicine versus another medicine. We will also sometimes take advantage of medicines that you're already on. So for example, if you have bad seizures and you're on a medicine like, let's say, clonazepam or clobazam, and you're having more seizures, we may talk to your neurologist and say, you know what, let's go up on one of those medicines at night, because that might not only help with seizure control, but it might also help with falling asleep. And so we might be able to take advantage of those other medicines that you're already on without having to add another medicine. And then the last part of insomnia treatment that we look into is other causes of sleep disruption. So if you have something like trouble breathing or obstructive sleep apnea at night, that could be causing you to wake up. And so there's a good chance, if you see a sleep doctor, that we would recommend getting a sleep study, or even doing some lab work where we collect blood to look for different things such as iron deficiency, which I alluded to before. For these circadian rhythm disorders or problems with your sleep-wake cycle, the most important thing to remember is consistent sleep habits, which means going to bed at the same time and waking up at the same time. If I had to pick one area to kind of focus on, it would ironically not be the going to sleep part, but it would be the waking up part that is more important. For example, you can't force yourself to go to sleep, but you certainly can force yourself to wake up, or you can force your child to wake up in the morning. If you're waking up in the morning at a consistent time, then by the time the nighttime comes around, you are more likely then to fall asleep more easily. The trick here again is consistency. And when I mean consistency, I mean every single day, including the weekends. The weekends are when most people like to sleep in, But if you sleep in, you run the risk of kind of undoing all your hard work that you did the week before. And so waking up at the same time is very, very, very important. Melatonin can be used to affect your rhythms as well. And so it can help you fall asleep, and it can also change when the brain wants to be asleep and when it wants to be awake. And finally, light therapy. Light therapy essentially means getting exposure to bright light right when you wake up. And I don't mean light in your home or overhead lights. I mean bright, bright light like the sun. So opening the curtains in the morning to let the sun in, or even sitting outside for 20 minutes in the morning as you're eating your breakfast or next to a window can go a long way in terms of helping you keep your sleep-wake cycles at the right times. If that's not enough, then sometimes we will talk to patients and their families about using a light box. Light box is basically, it looks like a tablet, and it shines very bright light at an intensity of at least what's called 10,000 lux, and lux means light intensity. And that is something that is shown in somebody's face, kind of to the side. You don't have to look directly into it, but it's just kind of shined on them for about 20 minutes every morning. And that can also be very effective in terms of helping treat the circadian rhythms. Restless sleep. So if you have iron deficiency, you might have restless sleep. You could have restless leg syndrome. You could also have something called periodic limb syndrome. Periodic limb movement disorder. Periodic limb movements are when you're having little movements at nighttime that can sometimes lead to sleep disruption. And a lot of times those things are caused by having low iron. So we will sometimes get a blood test to test your iron levels and to see if it's low. The test there is called a ferritin level, which is a little different than just getting a hemoglobin. So it's a very specific test that we look for. And if that number is low, then sometimes we will recommend supplementing with iron. And that can help with restlessness at night as well. For sleep apnea, for specifically obstructive sleep apnea, one of the mainstays of treatment for young people and kids is surgery. So when I mean surgery, I mean taking out the tonsils and the adenoids. The tonsils are something that you can see in the back of the throat, which we have a cartoon right here. The adenoids are very similar to tonsils, except they're in the back of the nose. You can't see those easily unless you stick a camera in the nose. And we often will take out the adenoids and the tonsils in order to open up the airway so there's more airflow so that kids don't have those pauses in breathing as much. That is usually the only surgery we do. Once in a while, we will do other surgeries where we operate on the palate. And I'm not going to go into all those, but there can be other options from a surgical point of view. PAP stands for positive airway pressure, or CPAP. A lot of mothers and fathers or different family members that you know might actually already be on CPAP for their sleep apnea. And what that is where you wear a mask at night that gives you your airway pressure to help keep things open so that they don't close off. CPAP is not something that we start lightly in a child, just because obviously a child is more often than not going to be resistant to wearing something on their face at night. A lot of adults can't even tolerate CPAP. And so if we are recommending CPAP, it is for a good reason. And usually it's because you've already had surgery, but you still have significant sleep apnea, and we need to treat it that way. The last way we treat sleep apnea, one of the last main ways, is with the use of nose sprays for allergies. If you have, especially if you had bad allergies, using a nose spray can keep your allergies kind of at bay and decrease swelling to help open your airway. Central sleep apnea is treated slightly differently than obstructive sleep apnea because here we use more oxygen and we may use different types of positive airway pressure other than CPAP with something called, such as something called BiPAP. For daytime sleepiness, we basically want to treat any cause of poor quality sleep or sleep disruption. We will sometimes adjust medicines if we think the medicines are causing significant daytime sleepiness. We always emphasize good sleep habits in terms of going to bed at the same time and waking up at the same time. And finally, if we do all those different things and even get a sleep study, but you're still very sleepy during the day, we may consider doing extra testing to look for things like disorders of hypersomnia And those are things like narcolepsy, which can sometimes also happen. I hope this was a helpful overview of the common sleep problems we see in CDKL5. Thank you very much for inviting me to speak, and have a great rest of your day.
Thank you, Dr. Rudock. It was wonderful. I think it ran the gamut of the many problems and questions that our caregivers have, especially sleep disruption being one of the major things that impacts the quality of life of both the children and the caregivers. I would not be surprised if we field a number of questions after we post this. Would you be open to us sending you some additional questions and fielding those in either a secondary presentation or maybe just a Q&A kind of blog post might be a good way to approach it?
Absolutely, I'd be happy to do that.
Fantastic. Thank you so much. We really appreciate you taking the time to do this for our community.
Thank you again for the invitation.